Could you both just address the issue that obviously a lot of patients with prostate cancer, the partner often has issues with estrogen deficiency. Their interest is often low. That needs to be addressed as well, surely.
Mm-hmm. The partner's feeling or the patient, you're saying? Because
the partner.
Uh-huh.
A lot of women who've gone through menopause, who've got low estrogen issues, they're not interested, or they may be interested. That issue is often ignored. We're focusing on the male partner and all the issues related to treatment, but we must remember that you're not going to get anywhere if your partner's not interested in the first place.
Right, which is why I said it initially, right? Like the narrative of the partner also has to be heard. And sometimes, again, you're exactly right. The focus is solely on the patient and we don't hear the story of the partner. In these intimacy exercises that we're doing, this is not an exciting way to get an arousal for just the patient. This is exciting for both partners. And so what we're really doing through these exercises is part of it is just increasing touch in general. When you increase touch and affection, just like even a slight touch, you start to increase that lust and desire for one another. So this is not just about the patient increasing their arousal and their lust and desire. It's equally, if not more, with the partner itself, because they've also felt disconnected throughout this whole process as well. So these exercises are mutually beneficial, and I want to make it clear again, and I said it before, that we don't just rush to do these physical exercises. I'm not rushing to the end of the exercises. We can stick on exercise 1 for as long as need be if there's not that excitement or high lust or desire level. You can just lay in bed and we can do these like simple touch exercises, which is more an affectionate, loving, and caring touch exercise as opposed to the end of the exercise routine, which is more the physical, sexual, intimate side.
We've heard about medications for erectile dysfunction. We've heard about penile injection therapy, penile implants. Actually, we did a radio show a few years ago on the penile implant. And just so you know out there, the patient satisfaction, 90%. Partner satisfaction was reported in the medical literature as 95%. So that's a good statistic to remember. But we talk a lot about what we can offer to patients medically. But how do patients get to see you? Can they self-refer? Is it covered by insurance?
Right, good question.
Do you get referrals from urologists?
Yeah.
How accessible is your service to patients that need your help?
You can reach out directly, but I get most of my referrals through urologists in the area because I'm a big networker in my area, and so there's a lot of urologists in Chelsea. So I primarily get my referrals through them, and I'm the only sex therapist in my practice. Everyone else is a nurse practitioner. So when I have no room for anybody in my practice, I have several clinicians and other sex therapists that I work with that I refer to. But you could reach out to me directly as well.
And a couple of questions that have been emailed in. One of the questions was, how do you bring up the inability to ejaculate with a new partner or prospective date? Obviously, lots of people are in long-term relationships, but for people who are not, how do they address the issues of sexual function with new partners?
I get that question all the time with people who are in the dating world, because dating is hard enough to begin with, right, for anybody. So how do I bring up this issue with a partner? I'll always say, look, like, regardless, there's never, like, the ideal moment. They're like, what do I wait for the person on the date to say before I can respond? There's never going to be the perfect moment. It's when you're feeling the most comfortable with your partner. Nobody's expecting to talk about sex regardless on the first, I mean, they could, but on the first or a second date, let's say. So when you feel that level of intimacy or connection with your partner, I would say to bring it up before you get intimate in a bed with somebody, because you're already anxious and it's going over your head over and over, like I said before, that song lyric. So by the time you're in bed, it's just like raging. So I would bring it up to them, like if you go on a date for drinks or dinner, wherever you're going on their date prior to getting in bed with them, just say, there's something I've been wanting to talk to you about, and then explain. But I've never had someone come in, I'm sure maybe one of you have had this experience, but I've never had someone say to me that I brought it up with someone and I received like a lack of empathy, or like the person walked out on me, because I mean, people are usually pretty understanding, but again, I would say bring it up prior to being in a bed with someone at home. That's the biggest takeaway.
So I think one of the biggest problems with addressing sexual function is it's often number 3 in the list of issues to address.
Yeah.
So patients come in, they're obviously wanting to know whether they're cured, they're wanting to talk about PSA, surgical pathology, continence. It's very difficult to have a good sexual experience if your continence is an issue. So unfortunately, it's often cure, continence, sexual function's often very low down the line. Some patients are well over a year out from treatment before the sexual function issues have been addressed. Question to Carolyn and Melissa. Why is it that we're so bad at leaving it? Why can't it be 1, 1, 1 instead of 1, 2, 3? Why can't we focus much earlier on addressing these issues? And if either of you could say a few points about prehabilitation rather than waiting until the insult's already occurred.
So one of the benefits of the prehabilitation, again, is engagement. So you're already part of the process before you even have prostate cancer treatment or very early on afterwards. But what it turns out is that one of the reasons that it goes on so long is because there can be some natural recovery. And so we do see, a year out from prostatectomy or some of the other more focal therapies, some level of the regaining of function. And I think that that's been the baseline at which we have been approaching this, is that it's not the urgent, but we have to let Mother Nature in some ways find out where the true baseline is. And oftentimes that takes time. Unlike what we see oftentimes with urinary incontinence after prostatectomy, if there's dysfunction of that sphincter and it is profound and it is stable at a 6-month time point, then that's an appropriate time to intervene if it's bothersome to you. So we have a little bit of more natural history that may delay treatment sometimes. And also, as you said, it's a social aspect. This is the last thing that you bring up, and sometimes you are very reticent to bring it up to your cancer surgeon. So, but they want to and need to hear what your goals for recovery are.
And I think sometimes it's just a question of time, isn't it? You've got X amount of minutes to go through the issues, and that's the last thing to be addressed, whereas if sexual function is important and patients are under the care of an andrologist who's specialising in the sexual function, not just their urologist, then often you're going to get much better care, more aggressive rehabilitation. Carolyn?
And we love seeing people ahead of their surgery. You can't. It's not working. Okay. I'll switch to So we love seeing what we call the prehab patients, where they come to see us ahead of time. But unfortunately, I think most patients only come to us afterwards when they start having problems. And I think a lot of that is just anxiety. You're so worried about your prostate cancer, about your surgery, your treatments. And so a lot of people just don't think about it ahead of time. So we found that kind of the referral pattern seems to be that couples who bring it up pre-op or who are just very sexual to begin with, those are the ones that usually come to see us first. But I think a lot of times people are just so overwhelmed, and I'll even have patients say, oh, they asked if I wanted to come see you guys, but I didn't think it would be an issue. And so a lot of times they're just kind of overly confident that their erections won't take a hit with the treatment, and so they don't think they need to see us ahead of time or even early in the process, and I think that's a big factor as well.
Laura, I want to bring you in here. We're talking about trying to address sexual function, but if patients are struggling a lot with the incontinence, that's obviously a huge factor in delaying recovery of sexual function as well. We've talked about, Kegel exercises, and obviously, even if patients are in the right hands, it's going to take time. So do you think that if patients come to you and say, well, listen, I know Kegel exercises may work, but I really want to get on and get a sphincter in early so that I can focus on my sex life. Is that something that you would offer early? Or do you think it's worth delaying to look for recovery from, say, physical therapy?
So I liked what, is it on? I liked what Dr. Kaufman said about the timing is very individual in terms of this doesn't...
Try the phone.
Testing? Yeah, better? Okay. So I liked what Dr. Kaufman said about the timing of these surgeries is very individual. It doesn't have to be every single person does step 1, step 2, step 3. Patients will come to me with very definitive goals in terms of I am ready to be continent. I'm ready to travel without an entire suitcase full of pads. I'm ready to start running again. I'm ready to play tennis. And I'm ready to have my sexual function back, and I cannot do that if I'm leaking urine. And surgical therapy for continence can be purely for regaining sexual function. There are patients who have leakage of urine really primarily with sexual function and very minimal leakage in the rest of their daily life. And that patient can still be offered a surgical therapy to improve their sexual function. And I do offer both, Melissa and I, or Dr. Kaufman and I both do penile implants and artificial sphincters as part of our surgical practice. And which comes first is completely up to the patient. As a surgeon, it doesn't, at least from my practice, it doesn't matter which is the one that is implanted first.
And again, trying to get to the right physical therapist. Often the best people don't take patients' insurance. Do you find that's a problem for some patients, getting the right treatment?
So we have excellent pelvic floor physical therapists associated with Sloan Kettering, but the majority of my patient population is coming to me from outside of Manhattan and sometimes outside of the state, and so it's just not an option to see someone at Sloan Kettering once a week. And I really find that most patients, we have some resources we can give them to help them locate a pelvic floor specialist, and the enormous majority of patients are able to find someone relatively local who is experienced. That at least has been my experience, and that's throughout different states in the area. And most are covered they can find someone who's covered by their insurance.
So we prescribe a lot of medications for preservation of sexual function and rehabilitation with Cialis, sildenafil, Viagra. For those patients where sexual function is not important, do you think there's still a role for having patients on medications like Cialis or sildenafil to improve their urinary function as well, or not?
So I don't prescribe them primarily for urinary function, and that may be partially a sort of where my practice is and patients often seeing myself and my colleague, Dr. Mulhall and yourself. And so it's not, I prescribe Cialis for the patients who still have a prostate for voiding function, but not typically after radical prostatectomy to improve continence. I do find that those medications, especially Cialis for voiding function, is one of the hardest when you mention patients having insurance coverage. That and the beta-3 agonist are the two hardest to get covered by insurance in terms of what we have in the voiding function sphere. And they're both really helpful medications. So hopefully that will change over time.
Another question we got was, can electric stimulation of the Kegel muscles help with urinary incontinence? Any role for that?
So when I tell my patients I'm not a pelvic floor physical therapist, and often it comes up, what are they going to do to me? And I say, well, I don't really know. But I know in seeing lots of people back that it is effective to some extent for many people. And in my experience in talking to patients about what it was like during pelvic floor physical therapy, it is extremely variable. I had a gentleman jumping on one leg while holding a pelvic floor contraction and showing me how continent he was. And he was very continent. So it's, I think jumping on one leg, electrodes, there's all kinds of different ways of doing this. And I think...
Was that your chairman?
I'm not telling who it was. I think that as Rachel was talking about, finding someone who, or I can't remember who talked about it, finding someone who you're comfortable with including your pelvic floor physical therapist is very important. So I tell people, especially when I'm referring outside of Sloan Kettering, if you meet the person and it doesn't seem like it's the right fit, we just find someone else. And so electrodes or not, jumping on one leg or not, there's probably someone who is a good fit for you. But yeah, I don't think it has to involve electrodes.
Melissa, Carolyn, we've talked a lot about the effect of hormone therapy on fatigue, low energy, low libido, but so are some of the other treatments like Zytiga, Xtandi, and of course for some patients the disease itself. How do we tease out? I mean, if the fatigue, so easy to label the fatigue due to hormones, but even the emotional effect can make people very fatigued. Do you ever have the situation where somebody comes to you and says, look, I'll accept that my cancer may progress by coming off the hormone therapy, but that's what I want to do because I'm so miserable with the quality of life side effects?
And as long as it's advocated by their oncologist, then why not try that? Right? It's an affirming situation for the patient to have that level of control, right? And as long as it's advocated and not going to be dangerous to the individual from a cancer perspective, then we would certainly, that's where intermittent hormone therapy came about, right? Was trying to preserve the quality of life for the patients in the interim times. So I would certainly advocate for that.
Carolyn, do you ever have that conversation where patients say, look, I want to just stop hormone therapy and roll the dice because the sexual side effects are so severe?
Well, for us, it's a little bit different because it's a little different in our practice because while we're urologists, we specifically focus on sexual medicine, so we're not really treating their prostate cancer. So no one's really asking us about stopping ADT, but certainly a question we get all the time is, I have prostate cancer. Can I go back on the testosterone therapy I had before? Or is it safe to initiate testosterone therapy after prostate cancer? And that's a pretty complicated discussion really outside the scope of today's conference. However, we do have hundreds of men who have a history of prostate cancer who are on testosterone therapy, specifically because a lot of their symptoms are so debilitating. So just because you have a diagnosis of prostate cancer does not mean that that's not an option for you. So I think that's something really important to discuss with your providers.
Don't run away. And also, there's lots of patients who've actually been cured of prostate cancer, but their primary care or urologist is very nervous about giving testosterone replacement. And a lot of that data is defunct, it's out of date, it was based on 4 patients in the 60s. So we certainly have a lot of patients in our practice who are cured and carefully monitored, but are doing very well on testosterone replacement therapy, which they were denied by other urologists. I think it's important to make that point. While you're here, I just want to ask you about stem cells as far as erectile dysfunction. You've touched on that, but question that we get asked a lot is the new data, and this is in the media a lot and in magazines about the P-shot stem cells. Thoughts on that? Maybe just elaborate.
So I think a couple of points on those. First of all, like we discussed earlier, the Sexual Medicine Society of North America and the American Urological Association say that all of those so-called restorative or regenerative therapies are experimental and they should only be done under a clinical trial, and that is not the way that they're being practiced. So if we're talking about shock waves, the P-shot or platelet-rich plasma, stem cells, none of those have been really studied vigorously. So shockwave has the most promising data, although we still don't know who benefits, kind of what dose to give them, how long they need it. And the important thing is that I think almost all of those trials excluded prostate cancer patients. So we don't even know the safety of doing restorative therapy that's supposed to increase blood flow into someone who has cancer. And then when you talk about P-shot, there's literally no human studies on P-shot for erectile dysfunction. There's only 2 rat studies, and they basically either poured platelet-rich plasma on the nerve at the time of the crush injury, which is like the rat model of a prostatectomy, or they injected it into the rat penis, again, at the time of the so-called prostatectomy. So that's completely different at how they're doing it in these clinics. And so we're very against those. We discourage people from going to them. And it's not to say that they might not work in the future, but we're not there yet. And really the safety and efficacy is completely missing from that piece. And so we do not recommend any of those therapies at this time.
I'm sure you've all had experience as well as of patients who've spent literally thousands of dollars seeking these treatments, and our patients are very vulnerable to being sucked into treatments where people are just out to make money from people who are looking to improve their sexual function. You touched on this earlier, Melissa.
We have actually a whole series of patients. There are some very amazing benefits to certain men's health clinics that are specified to try to treat these types of quality of life conditions for all aging men, not just prostate cancer survivors. But we have the problem is the follow-up that you receive at these locations. And we have a series of patients in our own practice who have undergone prolonged erections of priapism, who have ended up with complete loss of erectile function secondary to this that we published recently. And it's not an insignificant number of men who have these types of events occur. And these are just the ones that end up in our clinic. So just be thoughtful and be sure you understand all the potential implications of any of the therapies that you want to embark on. And although these are all experimental, the restorative therapies, particularly stem cell therapies, are very highly likely in the future, maybe 20 years from now, to have amazing benefit for a lot of different implications in urology.
There was a spell when patients were being offered sural nerve grafting for recovery of sexual function for men after prostatectomy. I never saw anybody that had any positive outcome from that.
No, we did a series at Vanderbilt as well, and there was no difference.
And any new drugs coming down the line? I mean, we've heard about Cialis, Levitra, Viagra. Lots of patients are taking them on demand. What are your thoughts about daily versus on demand? And also, are there any new kids on the block that are going to knock Viagra, Cialis, Stendra off the pedestal?
Unfortunately, some of the innovation in that space has declined secondary to it reaching a theoretical limit for pharmaceutical companies. You can look at pharmaceutical companies and kind of divine how big the patient population is or where the meter's moving based on how much capital they're going to gain basically from creating those. And when you have medications that are effective, that are off patent at this point, unless there is a new innovation at looking at the pathways of erectile dysfunction, there may or may not be things. Are you aware of anything that's directly in the pipeline right now? Because I'm not. Combining these therapies and choosing which one is a very individualized decision. So sometimes you can combine some of the treatment options that, including injection therapies, very sparingly with any of the phosphodiesterase inhibitor medications. And depending on some of the insurance coverages, whether you can have a daily dose of Cialis, depending on your other medications. So those are personalized decisions that we make one-to-one.
And of course, there are medications that work, but so often patients say they can't get coverage. In the UK, if you're diagnosed with prostate cancer or diabetes, you get these medications for free. How do you help patients where just getting hold of Cialis and Viagra?
Well, we use generics. So there's a generic version of sildenafil that's utilized for pulmonary hypertension, and you may have to take 5 of the pills, but it is a much less expensive, burdensome option for many men. So we'll utilize that type of therapy when we can.
Carolyn, you talked earlier about the importance of exercise for patients on hormone therapy. Not sure about your statistics, but certainly we tell patients that if you go to the gym and you're not on hormone therapy and you burn 350 calories, when you're on hormone therapy you have to work a bit harder and you have to burn 450 calories to get the sort of same benefit. A lot of patients who are on hormone therapy, it's hard to get motivated to go to the gym, but in those that can exercise and push through and try and build muscle, their side effects are often much better tolerated. What are your thoughts for patients who are still suffering with the side effects of hormone therapy? Do you think there's a role for either clonidine patches or Megays or even holistic therapies like acupuncture? Any thoughts on how to deal with the side effects of hormone therapy?
So I think, unfortunately, a lot of these side effects are just something that you have to kind of adapt to and deal with. Certainly, hot flashes, for example, the medications like progesterone or Megace that are used to treat those come with complications. So acupuncture seems to have a lot of promise because it can help manage your hot flashes and has no associated side effects, so that's a very good option. But certainly, as we were saying in that study, the men who were on exercise program, they had better energy, they had a better quality of life, they had enhanced muscular fitness. And so we really recommend a strict diet and exercise program, and a lot of patients might want to see a nutritionist. You might need to get a personal trainer because you have to be very strict about it. You have to kind of hold yourself accountable, and it's really those two things in combination that can improve your quality of life on these hormone therapies.
We've heard about focal therapies early this morning where we're treating less than the whole gland. There's new techniques coming out all the time for surgery to help us identify the nerves much clearer, for those nerves that supply sexual function, like the firefly, where we can try and see them and try and protect those nerves. We've heard about how radiation therapies are becoming much more sculpted on the prostate. You see patients with issues with sexual function all the time. Do you think that we are getting better at treating prostate cancer and trying to protect sexual function? Or are you seeing more of it because we're talking about it more and maybe hopefully better at referring patients with these problems?
I frankly think that we're seeing less, but it's not because of your focal therapy, it's because of active surveillance.
Do you think there are areas where we could do a better job? I mean, obviously, patients who have aggressive disease, sometimes you can't spare the nerves.
Absolutely.
One of my medical oncology colleagues used to say the number one cause of erectile dysfunction in his practice was death if patients weren't properly treated. Do you think there are clear areas where we could do better? Obviously, prehabilitation, you've talked about addressing the risk factors like diabetes, smoking, getting patients on medication, early referral. Any other tips for patients to, and for us as providers, to do a better job?
Early referral is one of the keys because I have no idea what's going to happen to any of us and in what time frame, right? The meteor may be coming right now, in which case where's the whiskey, right? But all I can tell you is that I don't know how long, but I do know that we can do everything we can in whatever time frame that is to optimize your quality of life and bring back your vigor and vitality for that time period. So having someone in the clinic as early as possible who has an interest in regaining function, regardless of the state of their disease, is an important conversation to have, because we can sometimes provide medical therapies and focal therapies, but what we can also provide is hope, right? That there's going to be a future and that it's going to be a quality of life that you anticipate for yourselves.
And I think also some patients have a lot of issues with the sexual function, the continence, but a lot of it comes down to bad expectation. We have not done a good job as a profession of setting patient expectation. If you're a patient who has high-risk disease, a Gleason 8-9 prostate cancer that's gone beyond the capsule, it's totally inappropriate to tell a patient, oh, get your prostate out and you're going to be fine, because there's a good chance you're going to need surgery and or radiation, plus or minus hormones. And I think that's why a lot of patients are angry. It's one thing to have the problem, but we have given unrealistic expectations as a profession. Thoughts on that?
So I think in general we do a really poor job of talking to patients about sexual side effects of their prostate cancer treatment. So I've had so many patients come and they say, no one ever told me I wouldn't ejaculate anymore. No one told me my orgasms might not be more intense. I've had patients who still desired fertility and no one ever had that conversation with them before their prostatectomy. And so that makes having children in the future a lot more difficult. And I think a lot of times it kind of goes back to just information overload. Sometimes maybe that was discussed and the patients didn't really have an opportunity for that to sink in. I think a lot of times that discussion is just not being had.